Yes, hello. I hope you guys are okay out there. I believe you're fine at your respective placement sites and units. Now, like we discussed earlier on, time is not on our side, and we're going to be covering most of our course units online. So there's this initiative that I've taken to discuss with you guys that we shall be using our online platform. So please allow me today discuss with you obstetric pharmacology, where we're going to be looking at antimalarials for midwives. My name is Joshua Oto. I'm a nurse educator. So what is malaria? I believe this is not something new to us. Malaria is a febrile illness that is caused by Plasmodium protozoa. There are 4 different species of Plasmodium that is responsible for causing malaria. We have Plasmodium falciparum, Plasmodium malariae, Plasmodium vivax, and Plasmodium ovale. Now, no antimalarial drug is effective against all 4 types or species of Plasmodium. Plasmodium is spread through a bite from an infected adult female Anopheline mosquito and can be transmitted by infected individuals via blood transfusion, congenitally, or infected needles from drug users. In the life cycle of Plasmodium, there are 2 independent life cycles. We have sexual cycle that occurs in the mosquito, and then a sexual cycle that occurs in the human being. Now, the knowledge of this life cycle is very essential for a midwife to understand antimalarial treatment. Most drugs that we use are only effective during the asexual cycle of Plasmodium that occurs in human, and that is the basis of our treatment or the basis of using antimalarial drugs. So here is a simple illustration of the life cycle of Plasmodium. Now, on our left, we have the sexual phase that occurs in a female Anopheles mosquito, and on our right, we have the asexual phase of the life cycle of Plasmodium that occurs in human. So, let us start from the sexual phase, where a mosquito will have a blood meal during which it injects sporozoites into the host blood. Now, these sporozoites will mature into primary schizones in the liver. They will move all the way through blood to the liver, then they will mature into primary schizones in the liver. Now, schizones are mature forms of Plasmodium. They are able to reproduce sexually. So they reproduce and produce merozoites, which are daughter cells of Plasmodium. Now, the merozoites that are produced within the liver can, one, enter a dormant state or a dormant form that we call secondary schizoids. That is usually within the liver, or they are also known as hypnozoids. Now, anytime these schizoids, secondary schizoids or hypnozoids can become active and cause a disease. Now, the merozoids still, secondly, can move into blood. Then they infect red blood cells. When they infect the red blood cell, this stage is called erythrocytic phase, where it occurs strictly inside the erythrocyte, or it's also known as the blood phase of Plasmodium infection. Once it enters the erythrocyte, it multiplies and develops new merozoites or gametocytes. The new merozoites causes the red blood cell to rupture. When it ruptures, antigens are released, male gametocytes are released, female gametocytes are released, and still more merozoites are released, which enters more red blood cells, causing more multiplication and development of the merozoites. Now, among the things that are released when a red blood cell is ruptured, we have antigens. Now, antigens are small proteins that are parts of the plasmodium. When these antigens are released, they are released into blood, then they end up causing chills and then fever. Meanwhile, the gametocytes that are released, the female and the male gametocytes that are released when the red blood cells rupture, may be taken up by a mosquito when it gets another blood meal from an infected individual. Now, this gametocytes moves up to the stomach of the mosquito where fertilization takes place. Now, after fertilization, zygotes are formed. Then in the gut wall, these zygotes becomes a cyst. Now, when a cyst is formed, that cyst matures into a sporozoites, completing the life cycle of Plasmodium. Now, this is very important, especially the asexual form that occurs in human, because one, we have drugs that targets tissue schizoids. They are called schizonticides. This drug targets schizoids that are within the liver. Then we have drugs that are called blood schizonticides. They are aimed at schizoids that are within the blood system, within the erythrocyte. Now, the other thing is that when you look at these merozoites that mature into secondary schizoids or hypnozoites, there are only two species of malaria that is capable of forming secondary schizoids or hypnozoites. They form dormant forms in the liver. One is P. vivax, then the other one is P. ovale. Only those two species of Plasmodium can form secondary schizoids. So that is about the life cycle of malaria, of Plasmodium. Now let us proceed and we look at the classification of common antimicrobial agents that are used. Now this is a chemical classification. Number one, we have cinchona alkaloids. A good example is quinine and then chinchonine. Then second, we have 4 aminoquinolones. Example is chloroquine, amodiaquine, hydroxychloroquine. Then thirdly, we have 4 aminoquinolones. Examples we have valaquine, primaquine, and permaquine. Number 4, we have 9-aminocritidine. Example, mepacrine. Number 5, we have biguanides. Example, probranil, cyclopranil. Then 6, we have pyrimidine analogs. A good example is pyrimethamine. Then 7th, we have polycyclics. Now these drugs are called polycyclics because they have a chemical ring that is described as polycyclic rings. A good example is doxycycline, which is an antibiotic, and then alofantrin. Number 9, we have artemisinin and its derivatives, which includes artetha, artemether, and artesunate. Then we have antimalarials that we classify them as miscellaneous. We have methalamine, sulfadoxine, and then mefloquine. So that is basically the classification of antimalarials. And let us proceed and we look at clinical uses of antimalarials. How do you use them, especially within Uganda health setting? Now, this clinical usage is based on the National Malaria Treatment Policy, then in the UCG 2023. So when you have uncomplicated malaria in all patients, including children more than 4 months of age and pregnant women in second and third trimester, the first line treatment is artemether and lumefantrine, what is commonly known as Coartem. Then the first line alternative is artesunate and amodiaquine. Now, if you don't have those drugs, or if they have failed, you have a second line, which we have dihydroartemisinin and piperaquine. They are all known as ACT, which means artemisinin combination therapy. Then for pregnant women in first trimester, ACT is used. ACT means artemisinin combination therapy, which may mean either artemether and lumefantrine, or artesunate and amodiaquine, or dihydroartemisinin and piperaquine. So that is the treatment of uncomplicated malaria. Then we have the treatment of severe or complicated malaria. In all age groups or patients category, the first line is IV artesunate. If you don't have IV artesunate, you have a first line alternative, which is IV quinine or artemether injection. Now, sometimes you're working in a lower health center whereby you don't have the capacity to handle severe or complicated malaria, where referral is the best approach that you can use. So in this case, you are required to give a pre-referral treatment, and in children less than 6 years or 6 years and below, you give rectal artesunate. So rectal artesunate is a pre-referral treatment in children less than 6 years. Then second line, if you don't have rectal artesunate, you can give IM quinine or artesunate or artemether. So that is the management of severe malaria using antimalarials. Then let's go ahead and look at the prophylaxis of malaria. One, in a pregnant women, we do what we call intermittent preventive treatment for malaria during pregnancy. The drug that is used is antimalarial, sulfadoxine, and pyrimethamine, which is a combined drug. Most midwives refer to it as SP, and it is also known as Fancida. So it is given starting from 13th week and given monthly till delivery. Then we have prophylaxis of malaria in sickle cell. Still, we can use sulfadoxine and pyrimethamine, which is Fancida, or the other alternative, which is actually first line, is chloroquine. Then prophylaxis of malaria in people living with HIV. Usually cotrimoxazole daily is given as per national guideline. Then we have non-immune tourists or visitors, especially those coming from Europe into the country. Now, malaria is a tropical disease, so sometimes they come and they're exposed to malaria. So what we do, we give mefloquine. Adults, you give 250 milligrams once weekly, or if it's a child, you give 5 milligrams per kilogram body weight once every week. Now, there are other drugs that are recommended for malaria prophylaxis. Number one, we have doxycycline, which is a tetracycline antibiotic. You give 100 milligrams daily, starting the day before traveling to the endemic area, and it's taken till 4 weeks after return from the endemic area. Then secondly, we have atovaquone, which is also used in the prophylaxis of malaria. So Let us proceed and we look at common antimalarials in midwifery practice. Number one, we have quinine. Now, quinine exists in two dosage forms. We have tablets of 300 mg and injection of 300 mg per ml. So the ampule is usually 2 mils. That means that it is 600 microgram, rather 600 milligrams in that 2 mil ampule. Quinine is classified as a cinchona alkaloid, that is its chemical class. Then its therapeutic class is an antimalarial. The mode of action, it's not well understood, but it is thought that quinine prevents heme metabolism, leading to heme accumulating to toxic levels in the parasite. This leads to death of the parasite. Now, in the clinical uses, quinine is used in one uncomplicated malaria. Here it is used as a second-line alternative to dihydroartemisinin and piperaquine. Now, it's a first line for children less than 5 kilograms or less than 4 months and in first trimester pregnancy. So in uncomplicated malaria, if the child is less than 5 kgs and less than 4 months, or a woman is in first trimester of her pregnancy, quinine is the first line drug of treatment. Then we have severe or complicated malaria, where it is used as an alternative to IV artesunate. Quinine is also given in pre-referral treatment of severe malaria. It's second line to rectal artesunate, where you don't have rectal artesunate but you want to give pre-referral treatment of severe malaria. You can give quinine, IM quinine. So dose and duration. In uncomplicated malaria, you give quinine orally 8 hourly for 7 days. In a child of 0 to 3 months or a child that is less than 5 kilograms, you give 10 milligrams per kilogram body weight. Then for a child that is between 4 months or 5 kilograms to 14 years but less than 50 kilograms, you give as per practical guidelines of dispensing lower health centers 2015. So for adults that are more than 15 years or they are more than 50 kgs, you give 600 milligrams. Those are 2 tablets. That is in uncomplicated malaria. Then in severe or complicated malaria, where you're giving a pre-referral for severe malaria, you give 10 milligrams per kilogram body weight as IV infusion or over 2 to 4 hours. So this is what you give whether it is severe complicated malaria or you're giving a pre-referral treatment for severe malaria. Then when you're giving quinine, it's supposed to run for at least 4 hours. Then you start a new infusion every 8 hours. Quinine side effects, we have chinchonism that presents as tinnitus or with deafness, visual disturbances, nausea, headache, and that is known as chinchonism. And then we have another side effect, which is irregular heartbeat, low blood glucose. But the quinine is very good in causing low blood glucose levels. Then we have itching, stomach upset, bitter taste in the mouth, black water fever, then kidney damage. Black water fever, if you have ever seen these people who become so ill of malaria that their urine turns dark, that is called black water fever, it is an indication that there is very severe hemolysis. A lot of red blood cells are being broken down and being excreted in urine. So that is why the urine turns dark. Now the kidney damage is coming about because of that dark urine that you're seeing. It's being filtered through the kidneys. Now that act of filtering may lead to accumulation of toxins within the kidney, leading to kidney damage. And quinine contraindications: you don't give when somebody has tinnitus, that is ringing in the ears. Then presence of hemoglobin in urine, you don't give it. Optic neuritis, you don't give it. Severe heart conditions. The quinine is very good at causing heart anomalies, so you don't give it in severe heart conditions. Hypersensitivity to quinine, hypotension, black water fever, myasthenia gravis, and glucose 6-phosphate dehydrogenase deficiency. You don't give quinine in those conditions. How about pregnancy? Yes, it's safe to use quinine during pregnancy. Breastfeeding? Yes, it's safe to use quinine during breastfeeding. So what are some of the nursing considerations that you must make when you're giving quinine? Number one, for solution for IV infusion, dissolve quinine in 5% glucose or 0.9% sodium chloride. But preferred is glucose. Why? Because quinine is known for causing hypoglycemia, which is low sugar glucose levels, which is low blood sugar or low glucose level in blood. Then secondly, quinine should never be given by IV bolus because lethal hypotension may occur. Then solution for IM injection, dilute to a concentration of 100 mg per ml. For example, an ampule of quinine is 600 mg in 2 ml. Therefore, you need to add 4 ml of water for injection to get 600 mg in 6 ml. Now, that will be equal to 100 mg per ml. Now, if you have this concentration, you can now give it as an IM injection. Then if the volume required is more than 3 ml, give half in the front part of the right thigh and then the other half in the front part of the left thigh. Do not give quinine IM in the buttocks. Use the outer front part of the thigh to reduce the risk of sciatic nerve injury. When you give quinine in the buttocks, there is a big risk of sciatic nerve injury. So therefore, we recommend that you give it on the front part of the thigh, whereby we don't have any major nerve that is passing in that region. Then still, the patient instruction, please tell the patient to drink plenty of sugary fluids during treatment with quinine. Why? Because quinine is very good at bringing down sugar levels in the blood. Then WHO recommends that quinine can be given with doxycycline when treating malaria. Please note that doxycycline is contraindicated in pregnant women and children less than 8 years. Therefore, in this population, if you are using quinine, it's better you use clindamycin instead of doxycycline. Do not use quinine for prophylaxis against malaria. It's not for prophylaxis, it's for actual treatment. Then if a patient vomits within 1 hour of taking oral tablets, repeat the full dose. And when you've been giving a patient IV quinine, when the patient is able to take orally, change the patient to more oral medications. So next we have artesunate, which is a very common drug in practice. It belongs to the class of artemisinin derivative antimalarial. In its mechanism of action, it produces free radicals and interfere with or disrupts membrane transport in the parasite. Now, free radicals are highly active compounds that take away electrons from the normal structure of an organism, leading to loss of structure in that organism. Loss of structure means loss of function. Therefore, this organism cannot function normally after its structure being interfered with. Artesunate dosage forms, we have suppositories of 50 mg and of 200 mg. Then we have injection. Injectables, we have ampoules containing 60 mg of anhydrous artesunate acid. There is also another separate ampoule of 5% sodium bicarbonate, which is used for dissolution of the artesunate or reconstitution. Then, what are the indications for artesunate? One, it's given as a pre-referral treatment for severe malaria, that is artesunate suppositories or rectal artesunate. Then two, it's given as an initial treatment of uncomplicated malaria when persistent vomiting precludes oral route. Now, sometimes we have patients who are vomiting very severely that they cannot take oral medications. So in this patient, especially children, you may opt for rectal artesunate because it won't be possible for them to vomit it. Then it's also given as first-line treatment for severe malaria. In all cases, artesunate is the first-line drug for severe malaria. Then dose and duration, how do you give? Pre-referral treatment of severe malaria and uncomplicated malaria. For a child and adult, you give 10 to 20 milligrams per kilogram body weight rectally as a single dose before referring the patient. And if it's uncomplicated malaria, you're still going to give it rectally, but once a day. In severe malaria, in an adult and a child, it's initially given by slow IV over 5 minutes. Then the quantity of the drug for an adult and a child, if they are more than 20 kgs or 20 kilograms, you will give 2.4 milligram per kilogram body weight. If it's a child that is less than 20 kilograms, you're going to give 3 milligrams per kilogram body weight. Give artesunate, give IV artesunate at 0 hours, that is known as the loading dose, then at 12 hours and at 24 hours. If there is no improvement, continue with the treatment once a day until the patient is able to take oral medication. So what are the side effects of artesunate? We have stomach upset, headache, dizziness, tinnitus. Pregnancy, do you use artesunate in pregnancy? Now, in the treatment guideline, artesunate is the drug of choice for management of complicated malaria. However, a study was done and they found that artesunate was teratogenic in rats, and scientists still believe that in humans it might also be teratogenic. Therefore, it is not encouraged that you use artesunate during first trimester of pregnancy. In breastfeeding, it can be used. Contraindications to artesunate: don't give it in non-hypersensitivity to artesunate, and don't give it in fast trimester because it is thought to be teratogenic. So nursing considerations when you are giving artesunate. 1. If it's rectal artesunate, the buttocks should be held together for at least 1 minute to ensure retention after rectal insertion. If suppositories are expelled from the rectum within 30 minutes of insertion, repeat the treatment. 2 to 3 capsules can be rectally inserted at the same time. If you have 4 or more capsules, first insert 3 capsules, then wait 10 minutes before inserting more capsules. So, the next drug that we are going to look at is artemether. Its class is artemisinin derivative antimalarial. The dosage forms, we have an injectable and which contains 80 mg per ml. So uses: 1. It's used in severe P. falciparum malaria. Then 2. Initial treatment of uncomplicated malaria when persistent vomiting prevents use of oral route. So what is the dose? In adult and child greater than 6 months, you give a loading dose of 3.2 mg per kilogram body weight by IM injection on first day, followed by 1.6 mg per kilogram body weight once daily for 3 days. So as soon as the patient can take orally, change to oral route and give a 3-day course of first-line antimalarial combination therapy. So what are the contraindications? 1. Children less than 4 months of age or those less than 5 kg. Then 2. Severe liver disease. 3. Severe kidney disease. 4. Pregnancy do not use in first trimester. However, during breastfeeding it can be used. What are the side effects? We have stomach upset, headache and dizziness, irregular heartbeat, and then the drug interactions. Now, artemether interacts with 3 main drugs. 1, we have azithromycin and erythromycin, where there is increased risk of irregular heartbeat. Then it also interacts with ciprofloxacin, where there is increased risk of irregular heartbeat as well. So there is a form of artemether where it is combined with lumefantrine. Now, this is known as artemisinin based combination therapy or ACT. Now, this combination artemether and lumefantrine is commonly known as Coartem. The dosage forms that we have tablets that contains artemether 20 mg and then lumefantrine 120 mg. It uses: number 1, it's first line therapy for uncomplicated P. falciparum malaria. What is the dose and duration? In an adult who is weighing more than 34 kilograms, you give 4 tablets every 12 hours for 3 days. Then for a child between 24 to 34 kgs, you give 3 tablets BD for 3 days. For a child between 15 to 24 kgs, you give 2 tablets BD for 3 days. For a child between 5 to 14 days, you give 1 tablet BD for 3 days. Below 5 kgs, you don't give artemether and lumefantrine. Their preferred treatment is quinine. Then what nursing considerations must you make when a patient is on artemether? 1. It should be taken with fatty meal or milk. Then 2. If vomiting occurs within 1 hour of administration, repeat the full dose. Number 4, use oral quinine in first trimester pregnancy and in children less than 4 months of age or those less than 5 kilogram body weight. Use quinine, not artemether and lumefantrine. Then, artemether and lumefantrine should not be used for malaria prophylaxis. It is for treatment, not prophylaxis. Then we have these very common drugs for the midwives: sulfadoxine and pyrimethamine, SP. Most midwives refer to it as Fancida. So Fancida is a combination of sulfadoxine and pyrimethamine. It is an antimalarial that is specifically used in the prevention of malaria in pregnancy. The class sulfadoxine belongs to sulfonamide or pyrimidines. Also, it can be classified as an antimetabolite. Then secondly, we have pyrimethamine, which is classified as a folic acid antagonist. In their mechanism of action, they hinder folic acid synthesis, subsequently disrupting DNA formation in the parasite. Now, DNA is responsible for life. If its formation is interrupted, it leads to death. Now, if Fancida interrupts DNA formation in the parasite won't be able to carry out its normal activity, therefore it will die. So dosage forms, we have tablets which contain sulfadoxine 500 mg and pyrimethamine 25 mg. This combination is what you give to pregnant women. So what are the uses? Number 1, it is used in intermittent preventive treatment of malaria in pregnancy, IPTP. This is what you give when the mothers come for antenatal care. Then secondly, it is used for prophylaxis of malaria in persons with sickle cell disease. However, it's not the first line treatment. The first line treatment is chloroquine. Then thirdly, it's used in seasonal malaria chemo prevention. Now, seasonal malaria chemo prevention is an approach to prevention that is upcoming. Like in this case, you see, I'll put in bracket, there's a pilot study being done in Karamojo. Now, scientists have discovered that malaria tends to be seasonal. It's not all the time. So there's an idea that what if during the seasons when malaria is very intense, we give a prophylactic treatment to people who are in that region that is at risk. So that is called seasonal malaria chemo prevention. So a drug that can be used is Fancida, which is sulfadoxine and pyrimethamine. What's the dose? You give 3 tablets taken every month starting from 13th week till delivery. This is the dose that you give to pregnant women in intermittent preventive treatment of malaria. What are the contraindications? Number 1, allergy to cotrimoxazole or sulfadoxine or pyrimethamine. Then 2, severe kidney disease, severe liver disease, first trimester pregnancy. Sulfadoxine and pyrimethamine is not given in first trimester. And lastly, HIV patients on cotrimoxazole prophylaxis. You're not supposed to give Fancida to HIV positive mothers who are already on cotrimoxazole. Why? Because cotrimoxazole and Fancida all contains sulfur. Now when you give both drugs, there is going to be too much sulfur in the body that will lead to toxicities. So it's not encouraged for you to give Fansida to a patient who is already on cotrimoxazole. So side effects of Fansida, we have stomach upset, blood disorders. Now, these blood disorders it's coming because of the antifolate activity of Fansida. Remember, I told you in that mechanism of action, they interfere with folic acid synthesis. Now, they can also interfere with folic acid synthesis within your body, leading to blood disorders. Then we have rash, sore throat, mouth ulcers, cough or shortness of breath, fatigue, and then headache. So in the interactions, Fansida interacts with three major drugs. Number one, folic acid, which leads to a cancer effect of Fansida. Then two, we have cotrimoxazole, where there is increased risk of side effects. Then three, we have methotrexate, where there is increased risk of methotrexate toxicity. Methotrexate is an anti-cancer that belongs to the group of drugs called antimetabolites. It's used in the treatment of cancer. It's also used in the management of ectopic pregnancy. So it interacts with Fansida. Then we have nursing considerations. What nursing considerations do you have? What should you think about when you're giving Fansida? Number one, discontinue Fansida immediately if blood disorders occur. Then two, Fansida is no longer recommended for use as treatment for P. falciparum malaria. Okay. When intermittent preventive treatment for malaria in pregnancy is given, withhold folic acid for 1 week after taking Fansida, then resume folic acid. So when you have given the mother Fansida, because Fansida interacts with folic acid, please tell the mother to stop taking folic acid for at least 1 week. Then after 1 week, you can resume folic acid. Then do not give Fansida in HIV positive patients on cotrimoxazole. We already talked about that because they interact. Then lastly, ensure doses are taken as DOT, that is directly observed therapy, meaning that you should actually ensure that you see as the mother takes Fansida. You don't give them to go and take it from home. Why? Because they may throw it along the way or refuse to take it or forget to take it, which is going to be bad. Because if that happens, in the next 1, 2, or 3 weeks, you will see the same mother coming back with malaria in pregnancy. So I believe this is basically antimalarials that we can cover under antimalarials used in midwifery practice. Thank you so much.